Hello and welcome. Today we're diving into a serious kidney condition called HIV-associated nephropathy, or HIV. We'll explore what causes it, how it affects the kidneys, who's at risk, and what can be done about it. This information is for educational purposes and shouldn't replace professional medical advice. HIV is primarily caused by direct infection of kidney cells by the human immunodeficiency virus, or HIV. Certain genetic factors, particularly in individuals of African ancestry, increase the susceptibility to developing this condition. The virus infects podocytes and tubular epithelial cells, leading to cellular dysfunction and ultimately kidney damage. Let's look at how HIV damages the kidneys. When HIV infects kidney cells, specifically podocytes, it triggers a cascade of events. Infected podocytes produce excess proteins, causing cell enlargement and eventual collapse of the glomerular filtration barrier. This barrier is essential for filtering waste from the blood. Tubular cells also undergo changes leading to protein accumulation and tubular damage. The overall effect is scarring and progressive kidney failure. HIV is more prevalent in individuals of African descent who are infected with HIV. While effective antiretroviral therapy has significantly reduced the incidence, it remains a notable complication, particularly in resource-limited settings where access to treatment is limited or delayed. The exact prevalence varies depending on the population studied and access to healthcare. The symptoms of HIV can be subtle at first. Common signs include swelling in the legs and feet, fatigue, and foamy urine, which indicates protein in the urine. As the condition progresses, individuals may experience high blood pressure, decreased urine output, and eventually, symptoms of kidney failure such as nausea, vomiting, and shortness of breath. Diagnosing HIV involves several steps. First, a urine test will reveal proteinuria or excess protein in the urine. Blood tests assess kidney function by measuring creatinine and BN levels. The gold standard for diagnosis is a kidney biopsy, where a small piece of kidney tissue is examined under a microscope. This allows doctors to see the characteristic changes associated with HIV, such as collapsing glomerulopathy. HIV doesn't typically have subtypes or classifications in the traditional sense. The defining feature is the collapsing glomerulopathy observed in kidney biopsies. The severity of the condition is usually staged based on the degree of kidney damage and level of kidney function. The cornerstone of HIV treatment is effective antiretroviral therapy, or ART. Suppressing HIV replication allows kidney cells to recover. In addition to ART-AC inhibitors or ARBs, blood pressure medications are used to reduce proteinuria and protect kidney function. In severe cases, dialysis or kidney transplantation may be necessary to sustain life. Management also includes controlling blood pressure, cholesterol levels, and managing other associated complications. The best way to prevent HIV is to prevent HIV infection in the first place. This involves practicing safe sex, avoiding sharing needles, and accessing pre-exposure prophylaxis, or PrEP, if you are at high risk. For individuals already living with HIV, early diagnosis and consistent adherence to antiretroviral therapy are crucial in preventing the development of HIV. With effective antiretroviral therapy, the prognosis for individuals with HIV has significantly improved. Early diagnosis and treatment can often stabilize kidney function and prevent progression to end-stage renal disease. However, if left untreated, HIV can lead to kidney failure and the need for dialysis or transplantation. Research continues to explore new therapies aimed at directly targeting the kidney damage caused by HIV and further improving long-term outcomes.